Okay, Joe, it is 2 o'clock and I know we've got some attendees still coming in, but if you want to get started, we have a lot to cover and I want to make sure you guys have enough time.
All right. Thank you, Amanda. So let's get started. Hello, my name's Joe Coletti, and I'm the account manager for Blue Cirrus Consulting. Our webinar topic today is virtual nursing. Heavy workloads, inadequate resourcing, burnout, and stress are leading nurses to leave the profession. When we lose seasoned nurses, we lose the expert knowledge they bring to patient care and to the profession of nursing. The nursing shortages are projected to increase over the next few years, which will exacerbate knowledge gaps further. Effective use of technologies to extend the reach of the expert nurse, regardless of geographical supply and demand, is an innovative approach solving the problems associated with nursing shortages. Today, we are going to talk with 3 experts on the topic of virtual nursing. With me this afternoon is Dr. Teresa Rincon. Teresa is a senior telehealth consultant at Blue Cirrus Consulting and assistant professor at the Graduate School of Nursing, University of Massachusetts Medical School. Dr. Rincon is an expert in strategic planning, implementation, and analysis of system design of clinical services. She serves and has served on multiple local and national clinical advisory councils and committees on a plethora of clinical big data research and telehealth topics. She has published more than... Hi, Teresa.
Hello.
Yeah, welcome to the webinar.
Yes, we have 2 exciting guests joining me today for our virtual nurse panel. I have had the privilege of knowing and working with both Dr. Fiona Winterbottom and Dr. Lisa-Mae Williams over many years. Fiona Winterbottom is a clinical nurse specialist and a nurse practitioner with pulmonary critical care at Ochsner Medical Center. She has been a nurse for over 30 years and has practiced in 2 countries and 7 different states. Dr. Winterbottom has spoken and published on multiple topics such as critical care nursing, critical care telemedicine, sepsis, rapid response, and resuscitation. Her most recent projects involve a culmination of those subjects into virtual nursing. Dr. Winterbottom is an experienced clinical nurse specialist with a demonstrated history of working with and in hospital and healthcare industry and is skilled in adult care, critical care, palliative care, healthcare information technology, electronic medical records, data analysis, quality improvement, and implementation science and clinical research. She is a doctorate in nursing practice, a certified advanced practice palliative care nurse, a certified critical care nurse, and a Team Steps master training. So we're so excited to have her here. We also have Lisa-Mae Williams. She's the operations director for the Baptist Health Telehealth Center and oversees telecritical care and virtual sepsis unit services. She has extensive knowledge and expertise in telemedicine infrastructure, operations, telehealth databases, research, and clinical outcomes, and is a sought-after subject matter expert in telehealth program implementation and operations. Dr. Williams' dissertation laid the foundation for ongoing research related to the determination of quality indicators associated with implementing telecritical care nursing practice, leveraging clinical and telehealth data to discover new knowledge related to epidemiological factors and the effectiveness of treatments and subsequent outcomes associated with telecritical care model. Dr. Williams has authored and published several peer-reviewed articles. She is also on the Center for Telehealth and E-Law CTEL Advisory Board and the CTEL White House Stakeholder Group. She has presented at multiple meetings at the White House to advocate for removing restrictions on telehealth services.
Wow, excellent. Well said. And we've established they are experts. Fiona and Lisa-Mae, welcome. We appreciate you taking the time to speak with us about virtual nursing. But let's start with you, Fiona. Please tell us how Ochsner is using virtual nursing as a solution to acute clinical and staffing challenges.
Yeah, I'd be happy to answer that question. We've been really using virtual services as a support for bedside staff. We actually started using services in our ICUs in 2012. So we've been doing that for quite some time. In about 2016, 17, we did start with some med-surg nursing, which was really looking at some kind of emergencies and then some of our admit discharge processes. So we used that briefly until COVID hit us. which is when it really got, right before that, we had kind of really got it moving. And then, as everybody on this call probably knows, in COVID, our telemedicine took off because it was one way that we could protect staff, we could still see patients, and we could really provide good care delivery with some quality. And that was a challenge, but we were lucky that we had a pretty good infrastructure for that. And so it allowed us to mobilize quickly, even to areas where we didn't have monitors, but we had the capacity to move them. And then subsequent to that, since we have monitors that we acquired through the COVID time, we are now figuring out different ways to leverage that technology. Now it's not being used in the way it was used during the COVID time. So I'll stop there and hand it over to Lisa-Mae, and as we go through, we can delve a little bit deeper. You're on mute, Joe.
Sorry about that. Lisa-Mae, please explain some of the use cases for virtual patient care at Baptist Health, South Florida.
So very similar experience to what Fiona described at Ochsner. So at Baptist, we've had telecritical care as a model of care for quite a few years, since 2005, 2006. And we've always known that virtual nursing, might have not called it that, but we knew that we could use nurses who were experts to provide support and to fill gaps in knowledge for novice nurses in the different hospitals. Prior to COVID and to the pandemic, we launched a program that we called e-coaching. And this was brought to us as a need from the teams in the hospital. And that's a key point of what I wanted to say, is that the teams in the hospital identified that this process, having remote nurses who were experts available, was something that they could leverage for their novice nurses. So what we ended up doing was developing a program that would support nurses post-preceptorship for 30, 60, or 90 days. And this was to help build their confidence and their critical thinking, because there was a large turnover within the first year. And that was the first, that we thought, well, we need to mitigate that first year turnover. And this is what we thought to do. During the pandemic, it became crucial because we had not only turnover due to people leaving to, for travel nursing, but then we also had travelers coming in and out. So the source of knowledge, of institutional knowledge, was very fleeting, except for those nurses in our telecritical care center who were lifelong nurses, average years, 17 years of critical care, more than some of them 25, 30 years within the health system. So they understood how the health system worked. And what we found that it was so successful that even though we did suffer like the rest of the country with the high turnover of nurses and an increase in a novice nurse to expert nurse ratio, we were able to retain a lot of the nurses past the 1 year mark, which was our goal. With the pandemic, we understood that it's just not in the critical care area that we were having a knowledge drain or brain drain. We saw that in step down. So we've launched the program in some of our step down units as well. And what is this program? If you mind me going on just a little bit more, just to explain. So we do have the knowledge of how virtual nursing can help with workflows and tasks, which is very important to be able to offload the tasks that nurses can do without freeing up time for them to spend with the patients, like, admissions, discharges, and things of that nature. But what we recognize is that nurses who were not confident and couldn't critically think it was a risk to the patient and to themselves. So we found that we needed to support those nurses transitioning. So we use, I don't know how many of you remember Dorothy Del Bueno from about 20 years ago, but she had a way to assess critical thinking of novice nurses. And that's what we used. We didn't reinvent the wheel. We use our expert nurses to evaluate these nurses post-preceptorship, and then their educator will let us know, based on the feedback that we've given them, how these nurses were doing and whether or not they were going to stay on with the e-coaching program. It has been a tremendous success. We actually have to kind of wait list other units that want to start it, but I'm just sharing this as a resource that we had that we were able to use. We didn't have to hire outside of the health system, and it has been a tremendous boon to our organization, and especially to critical care, where knowledge transfer has been an issue. So I know I went on for a little bit longer, but I just wanted to establish kind of the groundwork.
Thank you. Yeah, the groundwork is so important. And I think both Fiona and Lisa-Mae would agree with me in that this really isn't new. People think virtual nursing is new. I started as a virtual nurse, working half-time in a critical care unit and half-time in a tele-ICU unit in January of 2003. Now that's a long time ago, 20 years ago. So, and before that, nurses were being used in multiple different ways using telecommunication technologies. I know most of us in the audience, as well as here on the panel, we have spoken to an advice nurse over the telephone before. And really all we're doing is expanding the ability of the nurse to assess by putting audio video in their hands instead of audio only. And that's what we do in the acute care and the critical care in the emergency room spaces. And that's what we're seeing happen across the country in all areas of healthcare, not just in the hospitals, but really starting to use the practice of nursing and that expert nurse and disseminate them in their practice, really despite geographical boundaries. So I think that's the thing that I find so exciting about all of this work.
Excellent explanations. Yeah, it is available, and you need to reach out and look for it. Lisa-Mae and Fiona, what are some of the biggest challenges to starting in using virtual nurse services?
So the buy-in, of course, has been an issue with anything that is new or different that seems removed. They're like, okay, we have a staffing shortage, really a staffing crisis going on right now. So what I need is people in the hospital, hands on the patient. But we need to be able to understand that the resources that we have available, how to best use it. And so that communicating the needs of the different units is very important. And who do you go to for that? You listen to the nurses. What are the nurses telling you that they need? How are we going to best collaborate? So the challenges for the telecritical care team or the virtual nursing team, who, you know, for whatever we're doing, is to make sure that we're meeting the needs of the bedside team, what they need. We can't come to them and propose, hey, this is what we have for you. This is what we're going to do. It's never going to go well. So the collaboration really needs to be truly 70% their need and 30% our ability to bridge the gaps that they're seeing. One of the things that I did note with our team itself, that every unit had a little bit of a different deficit that they needed to meet. So we have a blood and marrow transplant unit. They are not comfortable having patients who are critically ill in their unit, but they were trained to do so. So it's an ongoing kind of carrying them through and making them comfortable with caring for these patients. They know blood and marrow transplant very, very well. They know cancer patients backwards and forwards, but the moment that patient now switches to deterioration, it gets a little bit challenging for them. So we're there in that moment. But then also understanding that in the ICU, these nurses who are doing this every day, they might not have the best way to communicate to the providers of what exactly they need to highlight for action to happen. So then they reach out and say, okay, let me talk to my telecritical care nurse who has all these years of experience and say, how's the best way to approach it? So teaching them the skills to how to communicate, and then understanding that collaboration really shouldn't be pushed onto them. It needs to be a pull just as much.
Okay.
Thank you, Lisa.
Yeah, Fiona, what are your thoughts? And also, I just want to make sure the audience knows you can post questions in the chat to the panel. So please feel free If something we're talking about just makes you think of something else and you just really have a burning question, pop it in there. I'm keeping an eye on that chat, so please feel free to ask some questions.
Yeah, Lisa-Mae brought up a lot of the same challenges that probably most of us have. The technology acceptance is big, and the units really need to be ready for whatever technology it is. It could be virtual in this way. It could be, we are using a lot of clinical decision support in partnership with our virtual services. So we're trying to utilize all the tools that we have. Challenges with finances, I know that's big, and I know Lisa-Mae's talked about this in many presentations she's done, that it costs a lot of money to have a virtual program. But if it's meeting the needs of the quality needs and then meeting the endpoint needs of the staff, then it's valuable. And so what we learned very early on, and this will be no surprise to anybody on the call, is that nurses want to take care of patients and they really don't love documentation. And so one of the hit strategies that we had was that we looked for things that we could take away from the bedside nurse, that they could continue to take care of the patient, but we could remove that burden of documentation from them. But in doing so, it not only took away something that they didn't want to do, and not that they didn't want to do it, they just wanted to spend time with the patient versus on a computer. But what it also did was it meant that we could streamline documentation, and it was improved because it was more consistently done. And so it was a win-win for both groups. And we did that with things like code documentation. When it's really an emergency, we were finding that staff was staying 2 and 3 hours after their shift to finish documentation. And then the documentation wasn't available for anybody else until after the nurse went home. So that then has other ramifications in terms of delays in care and things like that. So, so that's some of the things I would add to kind of things that Lisa-Mae's talked about. I think the culture is important, and anybody who's done any work on healthy work environment will knows that one unit is one unit is one unit. They're all different, and you have to be able to work at the unit level in terms of culture because it's very different. And one unit may take ideas from another unit, but they may not implement them in the same way. And so, so they're just some things I would say are things that we've been successful with. So I'll stop there and see if there are other questions. I see things going.
Yeah, we've got a few questions popping up, and that was kind of a perfect lead in when you spoke about healthy work environments, because the first question that popped up from Tom Bobich was around collaboration. And Lisa-Mae, you talked about collaboration, and you talked about it from a pull, but there's also a push and pull there. Can you talk a little bit more about collaboration? And for those that aren't familiar with the healthy work environments, that was founded by the American Association of Critical Care Nurses, and it has some key conceptual standards that we follow, and one of them is true collaboration. And so I'll have Lisa-Mae touch on true collaboration and how that works in her organization.
So having deliberately established relationships with the leaders within each of the facilities, it was kind of easier for us to be approached or to approach them when we saw maybe a quality challenge or something that we thought that they might be interested in collaborating on. But it doesn't start with virtual nursing. It has to start before that. Like what can we do to make ourselves available to them, to see what we can do for them. So it's a deliberate effort to build those relationships and having some sort of shared accountability with the team. So in our organization, some of our metrics are shared between our departments and the bedside teams. So for example, glycemic control, we both the bedside team and our telecritical care team have the same goal. So if we're intervening and if we're providing support and we're sharing with the nurse, hey, we noticed the blood sugars are not being controlled, tell me about it. So they already know why we're calling. They're anticipating that phone call because we have that shared accountability and responsibility for the outcome of the patient. In addition, we participate in their multidisciplinary rounds. So it's continuing on understanding it's not only about the nursing piece, but having them see the provider, the pharmacist, social work, and understand that we're all one team. And building that rapport and trust, we have ambassadorships. So even though we're virtual, we do provide opportunities for our staff to go and visit the different facilities. It's not something that we can do all the time, but at least twice a year, we have our team go out and then we invite the leaders and nurses from the bedside to come. So we're always trying to deliberately build that relationship, trust, and then understanding, and that builds that understanding and up for them to know what we can do for them. And so they then come to us whenever they have those challenges and problems and include us in building those solutions.
Thank you. That's such a great explanation. And I know I know Lisa-Mae's done this, and I know I have, is that healthy work environments. They do have a survey that you can have your nurses take, and we've used those to really look at our internal goals when I've worked with nursing units. And it's one of the recommendations I make in working with hospitals is to measure that culture. Do you have a healthy work environment? As Lisa-Mae mentioned, you've got to have that structure and culture in place. Trying to put in a new service line on top of a broken culture is not going to be successful. And thank you also, you touched on some metrics and some questions are popping up about how do you measure success? You talked about having goals, clinical goals. You talked about reducing nurse turnover. That was one that you spoke about. And so thank you for bringing those up. I want to hear from Fiona next. Like, what are some of the goals you guys work on? I know from a financial standpoint, one of the things we talk about a lot today is there's some data out there that suggests for every percentage point you reduce nursing turnover, you can save approximately $262,000 a year or each time. So as you see that reduction in percentage of turnover go down, when we see that go down, we're actually seeing a lot of money that's available. And I know that's considered a soft cost for the CFOs, but if you're bleeding out money right now from turnover, if you can reduce that, that's an important goal. But there's a lot of clinical goals. And I know, Fiona, you've done a lot of work on clinical things and financial. Can you talk about that a little bit?
Yeah, so we have a lot of things that we've done both with the virtual platforms and then with, just in our units. And same with, as Lisa-Mae said, we combine them because that this is a partnership. It's a collaboration. It's not something that one group does without the other. So I just learned the other day, the nurse who's been in our tele or our virtual nursing program for the least amount of time is 10 years tenure as a nurse. So they are very experienced, just like Lisa-Mae's program, and they bring that to the bedside for the novice nurses that we currently have, or maybe just transitioned nurses. So we are we're really looking at a lot of pilots right now, and using those kind of clinical endpoints to look at that. I'm kind of looking at the chat as we do that. One of the things we're piloting is sepsis on the floors. That's a huge cost to the organization. So it's an institutional kind of priority. And so we used a clinical decision support program with some interactive tools. We started kind of using it. The idea was to use it with the bedside nurses, recognizing that very quickly, the nurses couldn't really do one more thing. And so in order to really get the most out of the tool, which is, and then really look at how can you integrate that and look at, do we reduce length of stay? Do we reduce mortality? How does that benefit us? We've actually found that, particularly in one of our community hospitals, we've done all of the above. So we've improved documentation. We've been able to move into not just our med-surg floors, but our ED holding area, which everybody on this call is probably also having the same problem with ED holding. So we're looking at those patients. We've actually done it with cameras and without cameras, because you can actually do both. As you said at the beginning, Teresa, this was started with a telephone, right? And we have to be creative, because probably all of us are creative in our own ways to figure out what can we do. So when a CNO comes and says, well, can you do this without a camera? Well, we probably can. Let's figure that out. Let's figure out what we can do. There was a question in the chat about what type of monitors are they rolling. We've used carts, we used hardwire. It's a lot better to have hardwire. Probably everybody on this call would agree. You can use mobile things, but mobile things move. And when you're trying to be remote and somebody is moving your camera around, it makes it really, really difficult to actually monitor the patient. So we used tablets on poles during COVID. I mean, we used every type of two-way audio video device you could imagine to figure out how to actually care for patients. And I will tell you that hardwire is probably the best in terms of consistent monitoring of a patient. If you're doing episodic, you could probably get away with, mobile. I see Lisa.
Yeah, I see Lisa's
about
coming
to
off the
jump in,
mute.
so I'm going to let her go.
Well, no, but to piggyback on that, absolutely, hardwire is better, but you have to consider what is your goal of the intervention that you're doing. So is it that you need to assess that patient on an ongoing basis and you're doing continuous monitoring of the patient, you need access to view that patient all the time, then certainly hardwire is beneficial. But then we have times, for example, in our emergency department, we did attempt to do hardwire, but then the patient that needed the service was never in the room with the hardwired. So that turned out to not so beneficial. So it truly, there is a place for the technology. You have to make a decision as to, what technology works best for the protocol or the process that you have in place. And so, be agnostic with the technology, but understanding the limitations, as Fiona pointed out, with the mobile and wireless connectivity and broadband. And one of the things I will point out to you, that so the nurses have their workstation on wheels. They all know where the dead zones are. We won't know that. We're all the way 30 miles up the road. So we don't know where so they come and they bring the cart and they're like, oh, it's not working. So having a process to check the carts as you would your crash carts is very important. And that's one of the things that you have to do. It is cumbersome. It does take some time, but if you hardwire that process, then the carts functionality becomes less of an issue. And, so just to tie up that technology piece, but it's really not about the technology. As you can have carts and hardwired rooms, but if the nurses do not call or there's no process to integrate the virtual team, then it's pointless, right? Whether or not it's by the phone or in audio visual. So keep that in mind as you're building your programs, that you're designing you're not designing your program for the technology. The technology has to work for your program.
And it can't be passive. I think that's the one thing that's to piggyback on what Lisa-Mae said. This is not a passive process. So we have tried, the emergency department putting carts in if you don't have a designated person or a process that is going to make that cart get into that room, it's going to not be successful. So you have to kind of plan with that in mind, not, oh, we're going to put a cart over there in the corner and hope somebody uses it, because that's not really how it works. But it can be very effective if you have people that are interested and willing to use it. And I'll give you an example. We just started monitoring, doing sepsis monitoring on a unit where it is 100% agency, only agency on the floor. It's 34 beds. It's a step down unit. And they have embraced this technology. They call, they are invested, and these are temporary staff that are using this technology because they feel like it helps. We've already seen reductions in the amount of alerts the bedside staff are receiving. We've already seen deferrals go down and, you know, the kind of prompts that people get, which reduces alarm fatigue. We've seen an increase in the amount of sepsis screenings completed since we started, and we just started this December 12th. So, I mean, this is a month. And so adoption can be rapid when people are ready to receive the technology.
Absolutely. You both have made some excellent points about the technology and the workflows and the champions at the side of the technology that need to be in place. And one of the things we don't do good in nursing in general, there's a couple of universities across the country have started to do this, but is to really teach, even at Nursing 101, from when you're in nursing school, how to be that champion with the technology. So that facilitator who facilitates the communication and connection between the patient and the offsite or remote team, so that we can be effective in what we're doing. So there's a lot of workflow development that both of you guys do, a lot of training. We've got some questions about that, and I'm hoping that you can touch on that a little bit. Maybe Lisa-Mae, you can start and tell us a little bit about how you design those workflows so that you have that clear delineation of roles and responsibilities.
So fortunately for us, and again, the problem mitigated how we approach the solution. So fortunately for us, we have a team, a system-wide team called our Evidence-Based Clinical Care Council. And this team identified, let's use sepsis since Fiona was talking about sepsis, identified problematic DRGs. And at the time, sepsis was, one of the main challenges a few years ago when it became a core measure and we had to follow CMS, SEP1 bundle, et cetera. But what we found was a lot of the heavy lifting was on the nurses. The nurses had to do the screening. The nurses had to call the provider. The nurses had to call back the provider if they didn't hear from them in 15 minutes. Meanwhile, the clock is ticking. So we had our infrastructure for telecritical care already, and we thought, well, we have these critical care nurses here. They understand sepsis very well. They just need to understand timeline for CMS and working with the PI nurses to understand what they're looking for when they abstract and so on. So in that, the workflow came out of that need to offload those pieces that the nurses needed to do. So we had to have a screening tool that was automated. So the nurses didn't have to do manual screening anymore. So, but what that led to was a lot of alerts, as Fiona mentioned. Mm-hmm. So who is going to eat the low specificity of these alerts? Because it's going to be, everybody's going to have SIRS and organ dysfunction. But we don't know if the patient has, for example, an infection. That's the cause of it. So you needed a group of folks who were knowledgeable to eat that low specificity. And so what we did was develop our virtual sepsis unit. And out of that virtual sepsis unit, the workflow was then to take off from the nurses all of these additional pieces. And the only thing we call the nurses about is make sure to draw the blood cultures before the antibiotics. Remember the repeat lactic acid. That's it. They don't need to put in orders. They don't need to find a provider because we've now staffed it with providers. So out of the process, we understood that, hey, we need a provider here. So now we have nurse practitioners. So that's how the workflow develops. And as Fiona said, it is dynamic. It's not a static set it and forget it. You have to be flexible and to understand the needs and meet them there. So having also buy-in from your executive champions is a big deal, because if they understand what the benefits are, they certainly will support it and provide those resources. And then if you can show the value of that investment, not only the return on investment, but the value of the investment, they tend to support that. And so we now cover 184 units over 8 hospitals, ED, inpatient, off-campus EDs with a nurse practitioner, up to two nurse practitioners, or a nurse practitioner and 1 EICU nurse, 24/7, and that's it. And we don't have to hire this team for all 8 hospitals. So it's doable, but it only came out of that, having that conversation and meeting the need, because we could have run off and start hiring all these people and not understanding really what the need is. And it's been pretty effective.
Yeah, and I would
Good.
say we've learned a lot, you know, we learn a lot from each other. So I think for those on the call that are asking questions about ratios and how many, we have been running about a 1:100 ratio for our screening type activities. So like the sepsis screening, we started small. There was a question about, do people do it from home? So we don't start there. That's usually not the best place to start. Depends on, you have to know your team. So some of our team will do, sometimes if we wanted to extend our hours, or we're asked by our CNOs, et cetera, can you extend the hours further? These hours are difficult to staff with their lower, you know, night shifts, et cetera. Okay, well, we can, but that may mean that we ask people to do, you know, things from home, holidays, things like that. So once you've established, I think for us, we needed to establish the program first and understand what we were doing, because there's a lot of learning that happens in that space. Once you've done that, you can start to have people work from home, understanding that that presents a whole nother set of data integrity, validity. You've got computer problems, you've got confidentiality issues. So it opens up a whole Pandora's box of other concerns and issues, you know, Wi-Fi service, power outages, all these things that you don't really think about. We both live in the land of hurricanes, so we've learned to adapt when we don't have power for days on end. And so that's how we've tested that a little bit. And I don't know, Lisa-Mae may have more about what they do in their program, but we've certainly looked at it as an option, particularly for people during COVID that really couldn't be around others. So it was a way to protect them. So I'll let Lisa-Mae speak to that a little bit, because I know
And I just want to make sure we're cognizant of time, and there's a couple other questions I want to make sure we get to, but that was a very important point, Fiona. Thank you so much. And you talked a little bit about ratios, but I think one of the things that we've learned over time is it really depends on what you're having the virtual nurse do. If you would like a virtual nurse to, maybe because you need better expertise and consistency and standardization and how you manage your admission and discharge processes. Well, we know admissions and discharges take anywhere from an hour to an hour and 45 minutes per patient, depending on the complexity of the patient. So the whole process to do that. So if that's what you're having the nurse do, then you have to figure out how many admissions and discharges are those virtual nurses going to be doing at any given time period, so that you can figure out how many nurses you need, and then that will drive your ratio. And that's just one example. Sepsis surveillance is one you talked about, and you can probably look at more patients when you start to be doing just surveillance with clinical decision support tools that are there to help triage up the patients that you need to look at first. That again would allow you to have higher ratios. So it's really driven by the tasks. But one of the questions I want to make sure we don't miss out on, there's a question about liability. So have you guys ran into like increased liability using virtual nurses? I know I have not in my experiences, but what are your thoughts around the liability and following specific hospital policies and making sure that the virtual nurses are familiar with those?
So that is a great question. And I think it depends on who your virtual nurses are. So if you're hiring out a company, then that has to be a discussion. But fortunately for us, all of our team are employees of the health system. So our risk management absolutely loves us. And they have even, three of my nurses got great catch awards this past week. So they love us because they feel that this has reduced liability. We've not, knock on wood, had any litigation related to our virtual nursing or any of our programs in since 2005, so 0. And now I'm knocking on wood because I hope I didn't just jinx us. But even so, just so that question really comes down to the vision, or the what's the right word for this, how the organization views your work. So if they view the virtual nursing team as solving a problem that otherwise would lead to increased liability, then they're all for it. Our legal counsel has said from the get-go that our team needs to be documenting in the records. And why I bring that up, because not every telecritical care or virtual nursing program allows the nurses to document in the medical record for whatever reason. But they felt that this was evidence and to support what the care was that was being provided to patients from using this platform or workflow. Just a quick word about working from home, because that does involve, as Fiona rightly said, some liability as well. We have our nurses that work from home, and our nurse practitioners, they have to sign to and attest to a code of conduct, and that they're just as responsible for the information as if they were sitting in the patient's room. So they are very aware that, and we have them only use our health system laptops. They can't use personal laptops. And we are able to see what they're essentially logging into. They're not allowed to open the EMR when if they're at home but not clocked in. So that's one of the biggest things that they know. And so they have to sign a policy. They understand the risk to their career and livelihood if they really break any of these protocols. We do dissuade them from using the camera from home. But so they will do like admissions, and they will do the e-coaching on the phone and things like that. And so we built in our laptop, they have an application that they have their own extension once they're on the VPN. So it's as if they're in the hospital. So I just wanted to share that with you.
All right, we've got about 3 minutes left. So Fiona, any additional parting words, things that you'd like to make sure that we let the audience know about?
I think that this is a world of opportunity. I think that we're going to see more and more expansion of virtual health over the next few years. I think partnering with the medical record, we have a pretty close partnership, so that as we look to standardize, we can standardize through both platforms. And really make sure that we're providing the best patient care that we can. And ideas are always welcome. So some of the nurses at the bedside have the best ideas. And so take them and run.
Absolutely. I mean, I think both of you have touched on such important points around really defining what the problem is you're trying to solve. And then once you define that problem, you determine how can a virtual expert nurse or nurse practitioner step in and assist with solving that problem. How can you extend their practice over either telephone or audio video when you have that available to you? And then also you both touched on the importance of understanding what technology do you need to solve a particular problem, right? So if it's education for discharge planning with a patient, you could probably do that over the iPad. You probably don't need a high definition pan tilt zoom camera. So it really depends on what is it that you're doing, what's the service you're providing, and then that drives your metrics. So I know there was a lot of questions around metrics. That's going to drive your metrics. If you are looking at reducing time and improving discharge planning, then you're going to look at the ability to bring down the time from time of order for discharge to time the patient's walking out the door, and that you've been able to check all those best practice metrics of med reconciliation and education and other things that you would want to do. So these are the kind of things that we look for when we're helping organizations plan their strategies. What's the problem you're trying to solve? Then we can dig down into what are the metrics going to be, what's the service going to be, and what's the technology going to be. Any closing remarks, Joe?
Thank you, Teresa, Lisa-Mae, and Fiona for joining us today and sharing our expertise and experience. We are so grateful to have you. Thank you, everyone who attended and the great questions you've asked. We'll have a copy of the webinar posted on our website, blue-cirrus.com, and it'll be on our Knowledge Tsunami page. If you would like to talk with us more and have more questions, please reach out to info@blue-cirrus.com, and we'll be sure to follow up. Thank you. Have a great day.